The impact of 2024 CMS-HCC Risk Adjustment Model changes will no doubt be significant for Medicare Advantage organizations. Explore more in-depth analysis of these proposed changes, which includes multiple specific examples of how the proposed changes will impact risk adjustment. The proposed changes to the risk adjustment model would result in a 3.12% reduction to Medicare Advantage payments in 2024. CMS proposed to update the risk adjustment model by clinically reclassifying the hierarchical condition categories to reduce the impact of coding intensity on risk scores. Let's deep dive how coefficient factors will be changed in 2024. The risk score formula is equal to the sum of the demographic factors and the disease factors. The sum of those factors equals the raw risk score. Calculating risk scores requires specific demographic information, disease information, and other payment information. The demographic information includes beneficiary facts, such as age and gender, and includes certain beneficiary status indicators that enable grouping into similar segments, such as those living in the community versus an institution. Disease hierarchies address situations when multiple levels of severity for a disease, with varying levels of associated costs, have been reported for a beneficiary. The hierarchies prioritize the inclusion in a risk score of multiple HCCs where diagnoses are clinically related and ranked by costs. For risk score calculation, the disease and disabled interaction relative factors are added to the demographic and disease relative factors. Also, there are relative factors associated with the payment HCC count variables starting between 4 to 6 HCCs. The count variables are added to the risk score after the application of hierarchies. CMS then applies several methodological adjustments to the raw risk score. These adjustments are the normalization factor, used to keep the average risk score at 1.0, and the Medicare Advantage coding pattern adjustment, to account for differential coding patterns between MAUs and fee-for-service providers. The result is the payment risk score. HCC mapping from 2020 V24 to 2024 V28 is not one-to-one, and it is hard to map from V24 to V28 without diagnosis codes. Removes discretionary diagnosis categories from the payment model where coding variations are not clinically or empirically credible cost predictors. Principle 10 is a long-standing principle that is used as part of the standard evaluation of all of the risk adjustment models. Principle 10 states that discretionary diagnostic categories should be excluded from payment models. Diagnoses that are particularly subject to intentional or unintentional discretionary coding variation or inappropriate coding by health plans or providers, or that are not clinically or empirically credible as cost predictors, should not increase cost predictions. Excluding these diagnoses reduces the sensitivity of the model to coding variation and coding proliferation. As there is variation in the coding of discretionary conditions, meaning that the coding of these conditions is likely not consistent across the industry, including them in the risk adjustment model can lead to distortion of the marginal costs estimated by the model, reducing the ability of the HCCs in the model to predict stable costs and accurately predict those costs in alignment with the severity of the condition. This table is designed to compare HCC coefficient between V28 and V24. Neoplasms, cancers, heart, lung, and kidney conditions often see a positive impact to total normalized risk score under the V28 model relative to the V24 model. Diabetes, metabolic, blood, psychiatric, and vascular categories drive a negative impact to total risk score under the V28 model. CMS used a process referred to as constraining, where related HCCs are given the same coefficients. A significant example of constraining in the V28 model affects the diabetes diagnosis category. The contribution to the RAF score from diabetic disorders will not change regardless of whether the patient has uncomplicated diabetes or diabetes with complications. However, type 2 diabetes mellitus without complications, E11.9, for example, will receive a slightly higher coefficient in V28 than it currently does in V24. From 0.105 to 0.166. Overall, this will result in a significant reduction in the RAF score for patients with acute or chronic complications from diabetes. Coefficient comparison in liver, gastrointestinal, musculoskeletal, and blood disease group. Within musculoskeletal disease group, the HCC 94 systemic lupus erythematosus and other specified systemic connective tissue disorders will have its own category. Blood disease group will be one of the categories that will grow the most. It will have 7 categories out of 3 that it currently has. However, the blood disease group category is driving a negative impact to total risk score because far fewer diagnoses in these categories map to HCCs under the new model. Coefficient comparison in cognitive, substance use disorder, psychiatric, and spinal disease group. Over 50% of the ICDs mapping to HCC 59, major depressive bipolar disorder, have been completely removed from the proposed V28 model. There are 827 ICDs in V24 HCC 59, major depressive bipolar disorder. Among them 425 ICDs are not in V28, 367 ICDs are mapped to V28 HCC 155, major depression without psychosis, 27 ICDs are mapped to V28 HCC 154, bipolar without psychosis, and 8 ICDs are mapped to V28 HCC 152, psychosis except schizophrenia. Coefficient comparison in neurological, arrest, and heart disease group. Coefficient values for congestive heart failure groups are the same regardless of complication status. Vascular disease is by far the most impacted HCC, with over 82% average decline in the number of HCCs mapped under the V28 model. This decline appears to be driven by 2 main factors. V28 significantly decreased the number of ICD codes mapping to vascular disease, formerly HCC 108, now HCC 264. Under V24, 330 ICDs mapped to HCC 108, vascular disease, and 145 ICDs mapped to HCC 107, vascular disease with complications. Of those ICDs, 182 are no longer represented in the proposed V28 model. In one population, this decrease in ICDs accounted for over 98% of the reduction in the number of HCCs mapped. 2-for-1 ICDs have been removed from the MA model. Under the V24 model there were 5 ICDs that mapped to both HCC 18, diabetes with complications, and HCC 108, vascular disease. Under V28, one of those 5 has been removed and the remaining 4 map only to HCC 37, diabetes with complications. Proposed HCC 276, lung transplant status/complications, lies at the top of a hierarchy encompassing chronic lung disease to include a new category for severe persistent asthma. Coefficient comparison in skin, injury, complication, amputation, transplant, and openings disease group. HCC 176 complications of specified implanted device has been removed. New enrollees would benefit from the model change, whereas continuing enrollees with full partial aged segments would be most negatively impacted. New enrollee scores are dramatically higher in the new model, which dampens the overall risk score change. The impact to the new enrollee model is attributable to the increases in the demographic coefficients. New enrollee models do not include diagnosis codes in the calculation of the risk score. Disease interactions. Certain combinations of coexisting diagnoses for an individual can increase medical costs more than the additive nature of the CMS-HCC model predicts. There are some decreases in diseases interaction factors in V28. There are relative factors associated with the payment HCC count variables starting between 4 to 6 HCCs. The count variables are added to the risk score after the application of hierarchies. There are some increase in payment HCC count factors in V28. CMS uses the Part C CMS-HCC model to calculate risk scores for beneficiaries who are not in dialysis, transplant, or post-graft status. There are multiple segments associated with this model including the community, institutional, and new enrollee segments. There are 6 segments for community residing beneficiaries, 1 each depending on a beneficiary's aged and disabled status and their dual eligible status, whether they are full dual, partial dual, or non-dual. The institutional segment is used to calculate risk scores for individuals who are in long-term care institutions, including skilled nursing facilities, SNFs, for 90 days or more. The segment is determined by selecting the segment type, date of birth, aged greater than and equal to 65, disabled less than 65, and Medicaid benefit type. In 2024 version 28, full dual and partial dual aged segments show the biggest decrease in scores compared with the current model. The demographic information includes beneficiary facts, such as age and sex, and includes certain beneficiary status indicators that enable grouping into similar segments, such as those living in the community versus an institution. The models include variables for age and sex groupings. Please note, the terms gender and sex are used interchangeably. The age and sex variables in the model have associated relative factors published in the rate announcements. Age, for risk adjustment purposes, is the beneficiary's age as of February 1 of the payment year. The original reason for entitlement can be due to age, disability, ESRD, or a combination of disability with ESRD. There is an additional relative factor applied to the risk scores of beneficiaries who were originally entitled to Medicare due to disability. New enrollee model segments are used for aged and disabled beneficiaries who are new to Medicare or do not otherwise have enough diagnoses to calculate a risk score, operationalized as those who do not have 12 months of Part B in the data collection period. These new enrollee risk scores do not use diagnoses to predict costs and use demographic factors only. There is also a segment for aged and disabled new enrollees in chronic special needs plans, known as chronic SNPs. Let's examine how CMS-HCC version 28 will impact risk adjustment factor, RAF, scores. The following examples demonstrate the potential impact of the proposed changes on RAF scores, based on disease coefficients only, in 2023 versus 2024. The following examples demonstrate the potential impact of the proposed changes on RAF scores, based on disease coefficients only, in 2023 versus 2024. In our first example, there is a significant negative impact on risk score based on disease coefficients in a community, non-dual, aged 73-year-old female beneficiary with multiple conditions. Demographic, disease, raw, normalized, and payment risk score using version 24 are shown. Demographic, disease, raw, normalized, payment risk score using version 28 are shown in this example. This example demonstrates the potential impact of the proposed changes on RAF scores, based on disease coefficients only, in 2023 versus 2024. Significant negative impact in disease coefficients in version 28. This is another negative impact of version 28 changes. Demographic, disease, raw, normalized, and payment risk scores using the payment year 2023 CMS-HCC version 24 model. Although this patient's record also includes a diagnosis that newly maps to a payment CMS-HCC in V28, the disease component of the risk score is still lowered for the same multiple chronic conditions. CMS's use of constraining, where related HCCs like those for diabetes have the same coefficients, are also likely to impact RAF scores for a large percentage of patients. Once the changes are finalized, stakeholders will need to determine the overall impact based on their case mix, including changes that positively and negatively impact RAF scores. Another impact of the disease coefficient component of the risk score in a patient with multiple conditions, including a diagnosis that newly maps to a payment CMS-HCC in V28 such as alcoholic hepatitis without ascites, K70.01. A large number of relatively common conditions will not map to a payment HCC in V28, indicating that RAF scores will decrease for many beneficiaries. For more detailed information, please refer to the following documents. Please contact us if you would like to implement the value-based care solutions in your environment.